Good afternoon, everyone, and thank you for joining our Multi-Modality Imaging Conference. My name is Nadeen Faza, and I'll be talking about new frontiers in structural heart disease imaging and the role of 3D echocardiography. You can send in your questions by going to pollev.com. You can enter DeBakey, or you can text DeBakey to 37607 and text in your message. All right. The objectives of my talk are to highlight the role of imaging in procedural planning and intra-procedural guidance, and emphasize the role of TE and 3D imaging in structural interventions. This was just published by the ASE, which is the Guidelines for Standards for the Performance of TEE Screening for Structural Heart Interventions. I highly recommend that you look at this document. It was just recently published and highlights the screening process for these structural interventions. I'm going to start discussing transcatheter edge-to-edge repair of the mitral valve. As a quick overview, remember that MR etiology can be divided into primary mitral regurgitation and secondary mitral regurgitation. Primary mitral regurgitation can be due to leaflet perforation or cleft, mitral valve prolapse, or rheumatic valve disease, mitral annular calcification, or drug-induced mitral regurgitation. In contrast, secondary MR can be divided into atrial MR, which is secondary to atrial dilation, or functional MR secondary to non-ischemic or ischemic cardiomyopathy, and this is due to LV dilation and tethering of the leaflets. Different pathologies have different treatment modalities. The current transcatheter mitral valve repair devices include leaflet edge-to-edge repair, direct and indirect annuloplasty devices, and chordal replacement devices. Today, we're going to be focusing on the leaflet edge-to-edge repair devices. It's important to remember that the mitral valve is a 3D structure, and 3D imaging is very important to understand the pathology that involves the mitral valve. This is a surgical view or an en-face view of the mitral valve, where the aortic valve borders the anterior aspect of the mitral valve, so this is your anterior leaflet. The left atrial appendage borders the lateral aspect of the valve, so you have the A1 and the P1 as the lateral scallops, while the interatrial septum marks the medial aspect of the valve, and closest would be your medial scallops, A3 and P3. But how do you get this surgical 3D view? Remember that optimal 3D imaging relies on optimal 2D imaging. So first you want to make sure that you get your optimal 2D image of the mitral valve to include the annulus and the leaflets. You want to obtain a view where the mitral annulus is completely horizontal. You want to adjust the depth of the image and focus on the mitral valve. After you do that and get your optimal 2D view, then you set up your 3D zoom box to include the mitral valve annulus and the leaflets, and then your elevation width box to include the aortic valve and the mitral annulus, because your aortic valve is going to be your anatomical landmark. Once you hit 3D zoom, then you rotate your aortic valve to the 12 o'clock position, tilt over the image where you're looking directly at the mitral valve, and adjust the gain where you can see the leaflets very clearly. And this is how you get your 3D surgical view of the mitral valve. I'm going to discuss this case to highlight the importance of 3D imaging in evaluation of mitral valve disease. So this was a patient who had symptomatic heart failure and was referred to us for edge-to-edge repair of the mitral valve. And you can notice by 2D imaging that the patient had a flail posterior leaflet resulting in significant mitral valve regurgitation. By 3D imaging, in addition to the posterior medial flail that you can appreciate, there's an additional anterior leaflet cleft that was not very clear by 2D imaging. And that's why 3D imaging is very important when planning procedural interventions on the mitral valve. This does have procedural implications. So this is the flail, and this is the anterior cleft. And this was a study published in JACE where 1,000 patients were referred for TE, and those patients had unexplained MR by TE. About 600 of these patients had 3D TE imaging, and 3% of those patients were identified as having a mitral valve cleft by 3D imaging, again underscoring the importance of 3D imaging in evaluating mitral valve pathology. Other uses of 3D imaging in mitral valve interventions include the calculation of three-dimensional mitral valve area. This is specifically important in transcatheter edge-to-edge repair because if you deploy a clip in a valve that's narrow, then you can increase the risk of developing mitral stenosis. Again, the way you do this calculation is by obtaining your 3D mitral valve view, as we discussed before, and then with post-processing, you can measure the exact area at the leaflet tips. Usually an area of 4 centimeters squared is preferred when you're doing transcatheter edge-to-edge procedures. 3D imaging also helps determine the mitral regurgitation etiology. The first example is that of a P2 flail, and the second example is an example of functional mitral regurgitation, where you can appreciate the posterior leaflet tethering. Again, 3D imaging helps identify the site and extent of the pathology. This is an example of a focal prolapse at P2. In contrast, this is an example of a Barlow's disease where you have multi-scallop prolapse, and these patients are more challenging to treat with edge-to-edge repair. Sometimes the pathology can include the commissures. This is an example of a medial commissural flail, which is very obvious by 3D imaging. And if you want to be able to see it by 2D imaging, then you would have to use off-axis view to unmask this pathology. So again, 3D can be very helpful in looking at these commissural pathologies, and this is important for procedural planning. So what is the role of TEE in transcatheter edge-to-edge repair? Again, it helps us identify the pathology, confirm the severity of mitral regurgitation, and evaluate anatomical suitability for the procedure, including the site of pathology, leaflet length, width of the jet, and calculation of a 3D mitral valve area. In addition, it's instrumental in procedural guidance and detection of immediate complications. This diagram shows us some of the favorable anatomical characteristics when evaluating patients for transcatheter edge-to-edge repair of the mitral valve. Some of the favorable anatomical characteristics which translate to feasible interventions include pathologies that include the A2-P2 segments, lack of calcifications in the clip grasping zone, a mitral valve area of more than 4 centimeters squared, a flail width of less than 15 millimeters, and a flail gap of less than 10 millimeters. Challenging cases include severe Barlow's disease, calcification involving the grasping zones, and small mitral valves with high gradients. Again, with advancements in imaging and the different new devices that we have, we're able to tackle some of the more challenging cases. And imaging really helps us decide on which device to use for the intervention. This is a figure that demonstrates the newest mitral clip generations, which are the NT and XT-Ws. And the way that the devices are chosen are based on the posterior leaflet length. So the NT and the NT-Ws have shorter arms, so those would be used in cases with shorter posterior leaflets, while the XT-W and the XT have longer arms and are used in cases where you have longer posterior leaflets. The NT clip is used when you have borderline mitral valve area, while the NT-W is preferred for secondary MR. The XT-W, which is the larger and the wider clip, is preferred for primary MR with large flail or bileaflet prolapse, and the XT can be an adjunct to provide additional clipping for cases of primary MR. So when you're deciding on the clip to be used, things to take into consideration include the mitral valve area, the length of the posterior leaflet, and the width of the jet, and the mitral valve gradient. So these parameters always have to be taken into consideration when you're performing your baseline TE before such procedures. Moving on to procedural guidance, TE is instrumental in guiding the transeptal step, which is the first step of the procedures. And we use biplane imaging because this provides us with 2 orthogonal views of the fossa ovalis. This is a short axis view demonstrating the aortic valve, which marks the anterior aspect of the septum. And this is a bicaval view where the SVC marks the superior aspect of the interatrial septum, while the inferior vena cava marks the inferior aspect. The ideal transeptal puncture site for a mitral clip procedure is superior and posterior and about 4 centimeters above the mitral valve annulus. Again, this is biplane imaging showing that transeptal needle and that tenting resulting from the transeptal needle right before the puncture is performed. And the location is confirmed by 2D imaging. The interatrial septum can also be visualized by 3D imaging. This view shows us the fossa ovalis with the needle at about 1 o'clock. The aortic valve is towards the left of the screen, and the annulus is at the 6 o'clock mark. And here you're confirmed the tenting at the superior posterior aspect of the fossa ovalis, followed by the transeptal puncture. So this is a case of primary mitral regurgitation resulting from posterior prolapse, resulting in severe mitral regurgitation. Again, 2D imaging shows the site of the pathology, and this is very important because you want to orient your device, your clip, right at the site of this pathology. After the transeptal puncture, we advance the catheters, and then we advance the clip, the device. And this is a 3D view of the left atrium, including the mitral valve annulus. The way we get this view is by setting up our 3D zoom box to include the left atrium close to the roof. So you want to skip the roof so you don't get an artifact, but you want to include the mitral valve annulus and you want to include the entire left atrium, so you're able to visualize these catheters and devices as they traverse the interatrial septum. You then advance the mitral clip, open it, and you want to position it right above that P2 pathology, because your target clip position right here is A2, P2, right above that P2 pathology. And again, 3D is very helpful in orienting and placing the device. After that, the clip is advanced into the left atrium, and you would go to the grasping view, which is usually the lung axis view. You were able to see the aortic valve, and you're able to see the mitral valve leaflets. And you want to make sure you have enough leaflets going into the device before you close the device and deploy it. Again, you can deploy color to make sure that you're in that site of pathology. After the device is fully closed, then you would want to assess the amount of residual mitral regurgitation and the residual mitral valve gradient. If you have significant residual regurgitation, then the option would be either moving the device or deploying an additional device, or sometimes using a bigger device. This is a 3D imaging showing the tissue bridge at A2P2 with the clip in the middle, and this is an example of 3D color showing minimal residual mitral regurgitation. Things we rely on to confirm hemodynamic improvement after a clip is deployed is looking at the pulmonary vein. And in this case, we had systolic reversal at baseline. And then we ended up having a resurrection of the S wave after the clip was placed, indicating a reduction in LA pressures. In addition, the left ventricular stroke volume can be calculated by deep transgastric views. And in this case, we noticed that there's an increase in the LVOT stroke volume. Features of mild MR/LS by TE include significant reduction in color Doppler jet features, significant reduction in vena contracta by 3D color, and improvement or normalization of pulmonary venous flow. Additional features include improvement of forward stroke volume from the deep transgastric views, and new onset spontaneous contrast within the left atrium or the left atrial appendage. This is a study that was performed here at Methodist, which also showed that the vena contracta area of 0.27 centimeters squared had high diagnostic accuracy for moderate MR or less post-mitral clip. Switching gears to functional MR, which really tells a tale of two trials, the MITRA-FR and the COAPT, both published in 2018, and both studied the effect of transcatheter edge-to-edge repair in patients with functional MR. These two trials had very different results, where the MITRA-FR did not show any benefit in patients undergoing transcatheter edge-to-edge repair, whereas the COAPT trial showed significant benefit in terms of total number of hospitalizations for heart failure and even mortality benefits in such patients. So why were these trials so different while they were dealing with the same patient population? There are multiple possible reasons as to why the results were different, including the entry criteria for mitral regurgitation severity, guideline-directed medical therapy at baseline, and procedural complications and operator experience. But it's important to remember that the Mitra-FR patients had larger left ventricular end diastolic volumes and smaller effective regurgitant orifice areas. That essentially means that they had less severe MR and they had larger LV sizes. And if we look at the inclusion criteria for the COAPT trial, 85% of the population had an effective regurgitant orifice area of 0.3 centimeters or more, or pulmonary vein systolic flow reversal. So it's very important to look at such parameters when we're evaluating patients for interventions. Remember that the first step in management of functional MR is to optimize medical therapy. After you optimize medical therapy, if the patients qualify for CRT, then that would be the next step. And afterwards, you reassess your mitral regurgitation. If it continues to be significant, then they can be evaluated for transcatheter edge-to-edge repair if the anatomy is suitable. And this trial translated into the current guidelines, where secondary mitral regurgitation is first treated by GDMT, supervised by heart failure specialist, and then transcatheter edge-to-edge repair is performed for patients with favorable mitral valve anatomy, EF of 20 to 50%, left ventricular end systolic diameter of 70 millimeters or less, and a PA systolic pressure of 70 millimeters or less. And these criteria are based on the COAPT trial criteria. This is a case of a patient who presented with severe functional MR that was at the time of COVID, requiring an intra-aortic balloon pump. Because of the borderline blood pressures, we could not add a lot of medications, and the patient was in shock. The patient eventually underwent transcatheter edge-to-edge repair with 3 MitraClip devices, resulting in significant reduction in mitral regurgitation with a mean mitral valve gradient of only 3 millimeters of mercury. And the patient was immediately weaned off mechanical support and was discharged home. Some of the complications of transcatheter edge-to-edge repair include pericardial effusions or tamponade, right to left interatrial shunt, especially in patients with right-sided heart failure or severe tricuspid regurgitation, single leaflet device attachment, leaflet tear and perforation, chordal rupture resulting in flail leaflets, device embolization, and mitral stenosis. And TE is very instrumental in detecting these complications. For example, during a procedure, if a patient becomes hemodynamically unstable, that it's important for the imager to screen for a pericardial effusion, tamponade, use different views from the mid-esophageal views and transgastric views to detect such complications. As for follow-up using TTE, features of mild MR include a small area jet, lack of flow convergence, a systolic dominant pulmonary venous flow, an A-dominant mitral valve flow, and faint or incomplete mitral regurgitant jet. Features suggestive of moderate mitral regurgitation or more include a large jet area, flow convergence, systolic flow reversal in the pulmonary veins, a dominant E wave, and dense, incomplete MR jet. So these are things to look for after percutaneous interventions by TE. Switching gears to mitral valve replacement as the second procedure we want to discuss today. So transcatheter mitral valve replacement can be performed in patients with a native valve, and these are all under clinical trials at this point in the US. It can be performed when patients have prosthetic valves, so that's a valve-in-valve transcatheter mitral valve replacement, and patients with mitral valve rings, so that's a valve-in-ring TMVR procedure. It can also be performed in patients with severe mitral annular calcification. The first example is that of a patient with a surgical 31 millimeter biprosthetic epic valve who presented with significant shortness of breath. The TE was suggestive of significant mitral regurgitation. The patient was at a high surgical risk, so underwent TE evaluation. This shows us that there's a flail leaflet, biprosthetic leaflet, resulting in severe mitral regurgitation. So this is a case of mitral prosthetic valve dysfunction. Again, severe mitral regurgitation, and if you interrogate the veins, then you can appreciate the systolic reversal. The patient also underwent cardiac CTA for procedural planning. Given the high surgical risk, the plan was to perform a valve-in-valve transcatheter mitral valve replacement. And you can all download the valve-in-valve mitral application, where you can quickly plug in the type of bioprosthetic mitral valve that the patient has. And using the transcatheter heart valve selector, you're able to tell which transcatheter valves can be used for such a procedure. So this was live from the procedure. The patient underwent implantation of the SAPIEN 3 valve, which is balloon expandable, as you can see by the fluoroscopic images. These procedures are a bit technically easier compared to transcatheter mitral valve and native valve, because you already have a landing zone, you already have your prosthetic valve. So the risk of LVOT obstruction is less and sizing is easier, because you're not really, the landing zone is already present and you're not dealing with a dynamic mitral valve native annulus. These are some images post-deployment of the SAPIEN 3 in the prosthetic mitral valve, showing minimal mitral regurgitation. Leaflets were opening and closing well. This is a 3D image again demonstrating the transcatheter heart valve in the prosthetic mitral valve. Valve in native valve TMVR is more technically challenging as compared to valve in ring and valve in prosthetic valve. The challenges of transcatheter therapies for mitral regurgitation include the complex anatomy of the mitral valve and the mitral valve annulus, the proximity of the LVOT to the mitral valve, the valve thrombogenicity, long-term durability, and prosthesis anchoring and annular retention, because this valve has to withstand the systolic pressure that's being generated by the left ventricle. And transcatheter mitral valve devices have different anchoring mechanisms. Some rely on apical tethers, where you have a tether going to the LV apex. Others rely on annular winglets, native leaflet engagement, radial force, mitral annulus clamping, or external anchoring. So again, since the valve has to withstand the LV systolic pressure, the valve needs to have good anchoring mechanisms. And the Achilles heel of TMVR is really LVOT obstruction, because when you're performing surgical mitral valve replacement, then the anterior mitral leaflet is usually resected. But when you're doing a transcatheter mitral valve replacement, the anterior leaflet is still there, and if it gets pushed toward the LVOT, then you risk developing LVOT obstruction. So some of the risk factors for developing LVOT obstruction include having a long anterior leaflet, hypertrophy in the interventricular septum at the base, a small LV size, an aortomitral angle of less than 110 degrees. So these are all factors for developing LVOT obstructions, and these are all evaluated using CT. Some of the procedures that we can perform to mitigate the risk of LVOT obstruction include the intentional laceration of the anterior leaflet and performing alcohol septal ablation if there's basal septal hypertrophy. And CT is really instrumental in predicting LVO obstruction. So this is an example of a patient, again demonstrating the high feature risks, which include the small ventricle, asymmetric septal hypertrophy, perpendicular mitral-aortic angle, long anterior leaflets, and device-related factors. The LVOT obstruction is defined as an LVOT peak gradient of more than 10 millimeters from baseline, or a peak gradient of more than 30, or a hemodynamically significant of more than 50, an LVOT area of less than 1.7 to 1.9 centimeters squared. And LVOT obstruction can be predicted using simulation between the best fit prosthetic valve and the native valve, and calculation of that neo-LVOT area after the valve is placed. So this is instrumental before planning any TMVR procedures, because patients at high risk for LVOT obstructions are not good candidates for transcatheter mitral valve replacement. This was a case of severe functional MR performed years ago. Again, you can appreciate that the LV is dilated, there's tethering of the leaflets, and there is a central gap resulting in severe mitral regurgitation. In this case, we used the Intrepid valve, which is a transcatheter mitral valve, and it relies on the radial force for anchoring into the mitral valve annulus. This was a transapical procedure. So this is the finger poking test, where you see that the surgeons are poking the LV apex, which can be visualized by TE, and this is to confirm the ideal transapical puncture site. Again, CT is very instrumental in determining the optimal site for transapical puncture and helps in procedural planning. So this is the first step, which is identifying the optimal transapical site. This is followed by advancing the intrepid valve through the LV into the left atrium. Of course, you have to always monitor the subvalvular apparatus because of the risk of entanglement. Once that device was advanced into the left atrium, then it was deployed in the mitral valve annulus. And you have fluoroscopic images with angiography showing lack of significant mitral regurgitation. This is a 3D image of the transcatheter valve showing normal device function and a gradient of 2 millimeters. And there was no evidence of LVOT obstruction. It's always important to go to the deep transgastric views, look at the LVOT, get a PW and a CW across the LVOT to make sure that there's no LVOT obstruction at the end of the procedure. Switching gears to perivalvular leak closure, which is another transcatheter intervention that we perform and relies heavily on pre-procedural planning and guidance. This is an example of a patient with a mechanical mitral valve, and the question is, does this patient have perivalvular regurgitation? So you can see that the mechanical discs are moving well, and you see that there are these MR jets that are occurring within the valve frame, and by 3D imaging you can confirm that these jets are within your valve frame. They're not outside the valve frame. These are normal washing jets. So it's important to determine if these jets are originating within the valve frame or outside the valve frame. And the indications for percutaneous PVL closure include symptomatic heart failure or persistent hemolytic anemia with anatomical features that are suitable for percutaneous closures. The contraindications include active infective endocarditis, which can lead to PVLs, and significant dehiscence involving more than 1/4 to 1/3 of the valve ring. To demonstrate this using this case, so this is a patient with a bioprosthetic mitral valve, and you can appreciate 2 mitral regurgitation jets that are occurring outside the valve ring. You can see this by 2D imaging, then you can appreciate this by 3D imaging as well. Remember, this is our surgical mitral valve view, so the aortic valve is the anterior aspect of the valve, the appendage is the lateral aspect, and the septum is the medial aspect. And you can see by 2D imaging without color that there's a gap in the lateral aspect of the valve and a smaller gap in the septal aspect of the valve. The only way to confirm that these are true perivalvular leak defects is to apply color, because sometimes with echo dropout you can develop such defects. Once you apply color, you do confirm that there's a posterior lateral defect that's larger and a smaller anterior medial defect. Again, the patient was at a high risk for surgery and underwent percutaneous closure. So this is the baseline imaging followed by placements of the wire first into the larger lateral defect, again using combination of 2D imaging and 3D imaging, and you can see that the wire is crossing the lateral defect. Remember that these defects are not linear but can be oblique, and sometimes it's hard for the wires to cross them. So they're not always linear. We were able to cross the lateral defect and deploy a VSD occluder. And different devices can be used based on the size of the defect and the location. And these include VSD occluders, PD occluders, and vascular plugs. So in this case, we were able to deploy the VSD occluder in the lateral aspect of the valve, closing the lateral defect. And you can see here that there was only a trace MR anterior to the device. We tried to cross that medial defect. So again, this is looking at the valve from the left atrial appendage. This is the wire trying to cross the medial defect by fluoro and 3D, but the defect was small and was very tortuous, so we're unable to cross, again, the medial defect. This is at the end of the procedure. Things to look for include the gradient across the valve, because you want to make sure that the device, the closure device, has not interacted with the prosthetic valve, causing either regurgitation or obstruction. And then you want to evaluate the interatrial septal defect like we do with all the transseptal procedures. And using fluoro, we can also confirm that there's no interaction between the closure device and the prosthetic valve. And of course, ruling out a pericardial effusion at the end of each structural procedure. So this is an example of a PVL closure procedure. Switching gears to the transcatheter tricuspid intervention space, which is a newer space, a very exciting space. For a long time, the tricuspid valve was a forgotten valve, but not anymore. Now it's the cool valve. And echo is really instrumental in determining tricuspid regurgitation etiology, evaluating its severity, assessing the candidacy for percutaneous interventions, and facilitating intra-procedural guidance. Similar to mitral regurgitation, tricuspid regurgitation can be divided into primary versus secondary. Primary can be due to congenital defects, can be due to infection or inflammation, or can be due to radiation disease or carcinoid, or leaflet damage due to biopsies of the RV, leads, pacemaker leads, or blunt trauma. So these are some of the primary causes of tricuspid regurgitation. Secondary tricuspid regurgitation can be secondary to pulmonary hypertension, right ventricular myopathy, and increase in right ventricular volumes due to shunts or high output states, and can be idiopathic or atrial, as in the case of atrial fibrillation. And it's important to remember that different echocardiographic views can show you different leaflets of the tricuspid valve. That's why when you're evaluating a tricuspid valve for a potential intervention, it's important to look at multiple different views to be able to identify the exact site of pathology. So different TTE views give you different leaflets, and different transesophageal views can give you different leaflets as well. When we're doing a TE, it's important to obtain mid-esophageal views, but additionally deep esophageal views and transgastric views can be very helpful in identifying the leaflets, the pathology, and the target for intervention. Similar to the mitral valve, 3D views of the tricuspid valve are very helpful in understanding the site and extent of the pathology. So this is an example right there. So again, remember that optimal 3D imaging relies on optimal 2D imaging. 3D imaging will not give you beautiful views if you have poor 2D windows. So you want to optimize your 2D views. You want to get the tricuspid annulus in a completely horizontal plane. You want to adjust the depth of the image and adjust the focus and focus on the tricuspid valve. Then you'd want to set up your 3D zoom box to include the leaflets and the annulus. And then again, adjust the elevation width to make sure that the tricuspid leaflet and the annulus are included. Once you do that, you will hit your 3D zoom box and you will get your 3D zoom image. This is a case where you have a pacemaker, so it's very important to evaluate the interaction between the pacemaker leads and the pacemaker and the leaflets, because you want to make sure that there's no impingement on the leads that might be causing any tricuspid regurgitation. Again, this is key in planning interventional procedures. The landmarks we use when you look at the tricuspid valve include the aortic valve, which again marks the anterior leaflet, the interatrial septum, and this is your septal leaflet, and the other leaflet would be your posterior leaflet. And here you're able to see that the pacemaker lead is situated at the commissure between the septal and the posterior leaflets. The leaflets are moving freely, so the lead is not really causing any leaflet impingement. Again, you can get your tricuspid 3D TEs views from the RA view, looking from the RA similar to the mitral valve, a surgical en-face view in systole and diastole. And again, the anterior leaflet is closest to the aortic valve. The septal leaflet is closest to the interatrial septum, and the posterior leaflet would be at the posterior aspect of the image. Looking at the RV view, you can also identify these 3 leaflets. But is a tricuspid valve really a tricuspid valve? This was a really interesting study that was just published looking at the different tricuspid valve morphologies and the number of leaflets. And it showed that in 54% of the patients truly had 3 leaflets, the septal, posterior, and anterior leaflets. But there were different other subtypes that were described. For example, type 2, patients with type 2 had 2 leaflets, so they have the septal leaflet and the fused anterior posterior leaflets. Type 3A is where patients had the septal leaflet, a posterior leaflet, and 2 anterior leaflets, an A1 and an A2. Type 3B, which is the second most common type, is where patients had a septal leaflet, anterior leaflet, and 2 posterior leaflets. And type 2C is when they had 1 anterior leaflet, 1 posterior leaflet, and 2 septal leaflets. And finally, type 4 was when patients have 5 leaflets, so 1 septal, 2 posterior, and 2 anterior. Again, these are sometimes hard to appreciate by 2D imaging, so 3D imaging is really key in determining how many leaflets are there and where the site of pathology is. Again, this is instrumental in planning and guiding the interventions because you need to identify the target site for transcatheter edge-to-edge repair, for example. Which leaflets are you going to grasp together? Where is the jet coming from? So 3D imaging in the tricuspid valve is as important as it is in the mitral valve in identifying leaflet pathology and the site and the extent of the disease. And transcatheter tricuspid interventions is really a whole new world right now. And there are multiple different devices that can be used to treat tricuspid regurgitation, including coaptation devices, like the edge-to-edge repair devices, caval valve implants, which go into the IVC or the SVC, suture annuloplasty devices, or ring annuloplasty devices, and finally, transcatheter tricuspid valve replacement therapies. So again, different devices, and they all rely on evaluation of anatomical suitability for different interventions. The challenges of transcatheter therapies for TR include the large and dynamic tricuspid annulus, the elliptical annular shape, the absence of calcium, the complex right ventricular morphology, proximity to the coronary sinus, AV node and the His bundle, the vena cava, and the RCA. All these features make transcatheter therapies for TR more challenging. And this is a figure from the TriValve registry, which is an international registry of 312 patients who underwent transcatheter tricuspid interventions. And the most commonly used device was the MitraClip for edge-to-edge repair. And this study showed that a coaptation depth of more than 1 centimeter was independently associated with reduced success rate, which was a strong predictor of mortality. So again, these are things that we look for when we're evaluating patients with TR. So coaptation depth, the coaptation gap, RV function, and the leaflet anatomy. This is another study looking at 117 patients who were undergoing transcatheter edge-to-edge repair of the mitral valve. And it showed that predictors of procedural success included a coaptation gap of less than 7.2 millimeters and a center or anteroseptal TR jet. This is a case of a patient with severe secondary tricuspid regurgitation. You can see that the annulus is dilated, the leaflets are tethered, resulting in severe central tricuspid regurgitation. Again, patient was at a high surgical risk, and this is a 3D imaging, and you can see that the gap is mainly between the anterior septal leaflets and the posterior leaflet. And if you apply color, you're able to appreciate the site of the tricuspid regurgitation. This patient underwent edge-to-edge repair with the MitraClip devices. Here you see the first clip between the anterior and septal leaflets and the second one between the anterior and the posterior leaflets, resulting in significant reduction in TR severity. And similar to edge-to-edge repair of the mitral valve, intra-procedural imaging and guidance by TE is really key. Again, you place one clip at the site, at your target site, and then you reevaluate the residual TR and determine the need for additional clips. Lastly, I want to talk about left atrial appendage occlusion, another procedure that is performed transcatheterally and relies on pre-procedural imaging and intra-procedural guidance. Just a quick overview of the common left atrial appendage morphologies. So we have different types, including the windsock, the chicken wing, the cactus, and the cauliflower. And remember that when you're looking at your left atrial appendage, you want to look at it in different views, maybe use biplane imaging to unmask any additional lobes that might not be obvious using one view. So these are the main left atrial morphologies out there. And the common left atrial appendage occluder devices, including devices relying on the endocardial approach, and these devices are deployed via the transeptal approach, and these include the Watchman device, so the Watchman Flex, and the amulet device. The lariat device is a device that's performed by placing an endocardial and epicardial wires with a magnetic link, followed by epicardial suture ligation of the appendage, and this relies on combined epicardial and endocardial approach. Again, baseline imaging is very important before performing a left atrial appendage occlusion. The role of baseline imaging is to rule out the presence of an intracardiac thrombus. So you want to evaluate the appendage in multiple different views, and want to make sure that you're ruling out a thrombus. You want to make sure that you're seeing the actual tip of the appendage, make sure that the views are not foreshortened, and when in doubt, you can always use contrast to determine if a structure is a thrombus or if it's an artifact. Additionally, you want to evaluate for atrial septal aneurysms, interatrial shunts, mobile plaques, significant mitral stenosis, and pericardial effusions. This is a transeptal procedure, so these are things that you want to evaluate for. You want to evaluate for the plaque, because if the patients are presenting with a stroke, so that's another risk factor for having future strokes. I'm going to focus on the Watchman device for baseline imaging. So the baseline measurements for the Watchman device implantation are usually performed in multiple views, which are 0, 45 degrees, 90 degrees, and 135 degrees. So you want to perform these measurements at all these different angles, and the landing zone is defined as a distance between the left upper pulmonary ridge and the left circumflex artery, and the depth is defined as a distance between the landing zone and the most distal tip of the appendage. Again, it's important to visualize the left atrial appendage and make sure that you're visualizing the tip, because that will impact your measurement of the depth. Left atrial appendage sizing can also be performed by 3D TEE imaging. You want to obtain a 3D image of the left atrial appendage. Then you're able to get this on-fast look at the orifice area, and you can get your dimensions of the landing zone using 3D imaging. The first step of the procedure is a transeptal puncture, but unlike edge-to-edge repair of the mitral valve, your target transeptal puncture site is going to be inferior and posterior. So looking at the short axis view, you want to be away from the aortic valve, so you want to be more posterior, and using your bicaval view, you want to be closer to the IVC, which is more inferior. So the target site will be inferior and posterior, as opposed to superior and posterior for mitral valve interventions. And this is a 3D image demonstrating the transeptal puncture site. And here we're looking at the left atrium, and we're seeing that catheter go through the interatrial septum into the left atrium and into the left atrial appendage. 3D imaging really helps us appreciate the position and location of the guides and catheters we use in relation to the adjacent anatomical landmarks. So this is a view demonstrating the trajectory of the catheter for a Watchman device from the septum to the appendage. And the TEE views are kind of equivalent to some of the fluoroscopic views. So the right anterior oblique caudal view, which is RAO caudal, corresponds to the 135 degrees on TE, which is the lung axis, and shows the major axis of the left atrial appendage orifice. So if you think of it as a 135 view and then you rotate it, then you'll get the right anterior oblique view. Similarly, the right anterior oblique cranial view corresponds to the 45 degrees on TEE and shows you the minor axis of the left atrial appendage orifice. After the transeptal puncture, the guides and catheters are advanced into the left atrial appendage, and the device is deployed in the landing zone. This is demonstrating 3D imaging showing the appendage with the catheters inside the appendage, and then deployment of the Watchman device. And you can also see the corresponding fluoroscopic images demonstrating the deployment process. Before release of the device, 4 pass criteria must be met. So you want to confirm that the position of the device is stable. That's number 1. That's the P for position. You want to make sure that you don't have excessive shouldering of the device. You want to make sure it's in the right position and it's stable with no excessive shouldering. The second is the anchoring, and this is performed by a tug test where the interventional cardiologist will pull and push against the device to make sure it's stable in position. The third one is size, which is the compression. You want to make sure it's achieving 15 to 30% compression as compared to the original size. And lastly, evaluating for perivalvular leak to make sure that you have an adequate seal. The compression diameter is usually measured at the shoulder of the device, but you may have to make sure that the threaded insert is clearly visualized when you're making that measurement. So important to be able to visualize the threaded device before you make that diameter and confirm that there's enough compression of the device. Peri-device leak assessment should be again performed in multiple views, the same views 0, 45, 90, and 135, using an aliasing velocity of 20 to 30 to detect all these low flow velocities. And the largest peri-device leak is usually documented. Relevant peri-device leak is defined by the presence of colored Doppler jet of more than 5 millimeters for the Watchman device and more than 3 millimeters for the Amulet device. And again, 3D imaging can play a role in the detection of peri-device leak by applying colored Doppler by 3D and evaluating the site and the extent of the device leak. Complications of left atrial appendage occlusion include pericardial effusions, device embolization, vascular injury, and interference with the mitral valve function. And all these things can be detected by TEE. Similar to TMVR, CT is also very helpful in planning left atrial appendage occlusion procedures. CT can be used to measure left atrial appendage dimensions, can be used to rule out left atrial clots, and can be used to select the ideal transseptal site and the C-arm angulation in the cath lab. Follow-up imaging is performed 45 days after the initial implant, and the role of follow-up imaging is to establish device stability, the presence of a peri-device leak, and look for any device-associated thrombi, like the case right here, because the patients will be on anticoagulation for 45 days after the implant. And if you don't have any leaks, there are no thrombi, then you can take the patients off anticoagulation and switch them to antiplatelets. So the take-home points from my talk are that imaging is key in pre-procedural planning of structural heart interventions. TE with the use of 3D imaging is instrumental in procedural planning, guidance, and follow-up. And CT additionally plays a key role in procedural planning and prediction of complications. Thank you so much. Any questions? All right. I don't see any questions on the board and nothing from Zoom, so I want to thank you for joining us, and we will see you next week for another multi-modality imaging conference. Thank you.